you everyone for attending this session today. I'm sorry that I could not be there with you in person, but I have a newborn at home and it was too soon to take him on a plane. But I really am there in spirit. I love this meeting so much, and I'm excited to talk with you today about a very interesting new therapeutic option, an investigational therapy for systemic sclerosis. So we're going to jump right in. There will be time at the end for questions, so please feel free to think of them, and then we'll try to get to all the questions at the end. I've definitely left time for that in this talk. But I'd like to always start with the objectives of what we're going to cover today. So the first is to describe CAR T cell therapy, and I'll explain to you what that is, as well as the patient journey if you decide to embark on getting this type of therapy. We'll go through some of the known risks and benefits of CAR T therapy, and then even discuss some alternative cellular therapies that are emerging for research purposes. And then finally, because all of these therapies are still considered investigational, in order to receive it, you'd have to participate in a clinical trial. So I wanted to equip you with some of the knowledge about things you might want to consider if you're thinking about doing a clinical trial that's very specific to this type of therapy. So I know there's another session at this meeting on clinical trials, but I've tried to tailor this discussion specifically to this type of therapy because it's a very different type of therapy than just getting a pill or an infusion of a medicine. So what is CAR T? Well, first of all, it stands for chimeric antigen receptor cell therapy, but fortunately we can just easily say CAR T cell therapy. And if you've never heard of this, don't be alarmed. It's very new on the horizon for autoimmune disease, but it's been used for decades for the treatment of cancer. So it's been around a long time, but for other disease areas. And what does it really mean? Well, the first thing to know is that most of these therapies will utilize your own cells. So you have something in your body called T cells, and this is a part of your immune system. And it's a part of the immune system that exists to try to attack and kill foreign things. So if you get exposed to a virus, your T cells will react and produce a lot of T cells to then kill off that virus. But what this therapy does is it takes your own T cells and then in a lab engineers them genetically so that they put them back into your body to not just be designed to kill off viruses and foreign invaders, but to actually start to attack the parts of the immune system that are causing your scleroderma. And one of the things that's most promising about this therapy is that it does it in a very selective way. So it goes after a certain part of your immune system that we think plays a big role in causing your scleroderma without going after your whole immune system and causing a lot of immunosuppression, which is what happens when you take certain medications that we have that work more broadly, things like mycophenolate and cyclophosphamide. So what is the process like? Well, to get your T cells from your body, it just requires getting blood from you, which I'm sure many of you are used to giving your blood for testing, et cetera. But this would be taking your blood for therapeutic purposes. And then in a lab, we would isolate out your T cells, and then it would undergo this genetic manipulation to insert a gene into your own T cells so that it's modified in a way that when it's put back into your body, it would then target specific cells that we think are causing the scleroderma. So it's a very sophisticated approach. And like I said, it's been used a lot in cancer for many years to treat diseases like lymphoma, but it has not been used a whole lot for autoimmune diseases yet. So what cells are we targeting? Most of these therapies that exist and are emerging target a part of your immune system called B cells. So the T cells, again, are what the CAR T is based on, but they're attacking B cells. And B cells, another term for it is your antibodies. So these are the cells that remember and go after also attacking bacteria and viruses to help you fight infections. But we think B cells play a big role in causing inflammation in scleroderma and also perpetuating fibrosis or scarring. And I wanted to show a figure here because we actually have existing therapies that also target B cells. So one of them is a medicine called rituximab, and some of you may have heard of this medication or even be receiving it. And this medication also selectively targets B cells, and it targets B cells that have something on it called CD20. And so the rituximab works in this way as well. So you may ask, well, if we have rituximab, why would we need to do CAR T? And the reason is that rituximab has to be redosed. So we know that it goes after mature B cells, but then your body starts to produce more B cells. And so every 6 months, you have to keep getting the rituximab. Whereas with something like CAR T, we think that it would lead to a more sustained remission and hopefully kill off these B cells that are causing problems for you in scleroderma. And the promise is that they wouldn't come back, or they wouldn't come back for a long time. So you wouldn't have to keep getting redosed with your own CAR T cells. It's hopefully supposed to be a one-time thing. And so the figure on the right just shows an example. And again, this is kind of our cartoon, but of a CAR T cell. So one of your T cells that's been engineered to attack the B cells. But again, it's working in a similar way as rituximab, but the idea is that you wouldn't have to keep receiving it every 6 months like you would with rituximab. So why do we go after B cells in scleroderma? So B cells are the antibodies, and some of you may have heard about what antibodies you have. So you might have the anti-nuclear antibody. Most patients with scleroderma do. Some people will have the SCL70 antibody or the centromere antibody. And all this means is that, you have antibodies that probably play a role in causing your specific type of scleroderma. So what do antibodies or B cells do? They promote inflammation, but now there's more and more evidence that they do it in a way that can help perpetuate fibrosis. So they're not just involved in inflammation, and they're also involved in laying down that collagen, which can happen in the skin, in the lungs, and other organ systems in the body. And we know from our clinical and translational research that B cells play an important role in almost every aspect of scleroderma. So this is a picture of some of the common manifestations that occur in scleroderma. And so, for example, there's evidence that B cells play a role in causing the hand puffiness and joint swelling. They definitely play a role in perpetuating inflammation and fibrosis in lung disease, like pulmonary fibrosis. They're even implicated as being important pathogenic players for GI problems. So, for example, researchers have discovered anti-muscarinic receptor antibodies in patients with scleroderma. And these are antibodies that go after the parts of your GI tract that control motility. And so they may be important in terms of driving the dysmotility that people experience. So either slow transit in their gut and constipation. There's evidence that they might be involved in kidney problems, even in Raynaud's, cardiac involvement. They're definitely involved with people who have muscle inflammation as part of their scleroderma. I mentioned the arthritis. They're also found in skin lesions, and even something like digital ulcers. B cells have been implicated at causing some of the vasculopathy. So this is one reason why these therapies are going after the B cells. They just seem to be really important in causing a lot of problems in scleroderma. So the idea is that if we kill these cells off, maybe all these things could get a lot better for you. So the patient journey, it's not as easy as taking a medication and just going in for an infusion one day of Rituxan. It's a journey. So you would have your blood collected, and then in the lab, the T cells would be isolated. They would undergo modification genetically. And then they actually put them in an area to multiply. So they start to repopulate a lot. So that way, when they infuse them back into you, they're not just doing a few T cells, they're doing lots of T cells. And before they get reinfused infused in you, you would undergo a conditioning regimen. So this regimen would consist of medications to really, wipe out your immune system so that all the bad things are kind of cleared away so that these T cells can come in and really do their job very easily and effectively. So part of that process is receiving medications like cyclophosphamide and fludarabine, and these have side effects, and we'll go through some of them later in the talk. So what is the evidence in scleroderma? Because I mentioned that this is now only available as an experimental therapy. But there was a study that was published last year in the New England Journal of Medicine, and this is our premier medical journal. So it was a very good study. And it was small though, right? They just looked at patients with 3 different types of autoimmune disease. So they looked at 8 patients who had lupus or SLE. They looked at 3 patients with idiopathic myositis, which is abbreviated here IIM. And then they looked at 4 patients with systemic sclerosis or SSC. And these are the outcomes from this study. And these are outcomes at 6 months after the CAR T. And I will tell you that all of the patients with systemic sclerosis who participated in this study, it was done in Germany, were patients who we considered to have refractory disease, meaning they were patients with severe skin or lung disease, and they weren't getting better on traditional therapies like mycophenolate and nintedanib and rituximab. They kept getting worse. And so these weren't just patients this was their first treatment in scleroderma. They were patients that were really treatment resistant. And what's really fascinating is they all got quite a lot better. So this is a closer look at those 4 patients. The top row here is looking at changes in their U-star activity index. And this is basically a global measure of disease activity. So as the score goes down, the disease activity gets better. The second row here was their MRSS or skin score. And some of you may be familiar with this if you go to a scleroderma doctor and they pinch your skin in different areas, you know that it can change from visit to visit. So as the score goes down, that's improvement in the skin score. And there were some profound improvements in some of the patients. So patient number 14, for example, had a decrease over 6 months of 17 points on the skin score. That's fairly profound. I think with our other medications we have in scleroderma, we hope to get over the course of 6 months, maybe a decline by 4 or 5 points, but 17 is quite large. But you can see there was variation. One went down by 5. And these other rows here represent the patients who stayed off of any other immune suppression. So meaning that they got the CAR T infusion and they got so much better that they didn't need to get medications like mycophenolate or other drugs after it was given for 6 months. And the next row was those patients who would maybe need steroids. And again, none of the patients did. So, this was really exciting to see for the first time a therapy like this applied in a relatively small autoimmune disease population, but certainly all of the patients improved. And this figure here just kind of graphically demonstrates what I just spoke about. So this is the U-star activity index. Each of these lines represents a patient. And so they measured it at 0 months, 3 months, and 6 months. And in all the patients, it went down. The same with the MRSS or skin score. It started out pretty high for some patients, over 30. And again, 3 months and 6 months, it went down with one patient who didn't have it done at 6 months. So there are some limitations of this study, and I'm a clinical and translational researcher. So when I read a study, I'm really going through it with a fine-tooth comb because I want to know, is this medication or intervention going to help my patients, and what are some of the weaknesses of the study, and how can I apply this to my clinical practice? So, this is why when you read research studies, it's important to have them digested by someone that really understands research, because sometimes it can get misrepresented online or on social media. But I would say, in terms of my critique of this article, there was no control arm. So what this means is that most of the time when we're testing new treatments, we like to have a group of patients receive the treatment and then another group of patients not receive the treatment, to see, does the treatment really help? Is there a benefit? And in this study, everyone got the intervention. So we don't have any way to compare with a group of patients who didn't get it. And I mention this because sometimes patients with scleroderma, even without therapies, can have improvements in their skin disease that just happen over time. And we know this from older studies that were done before we had treatments for scleroderma, where patients were just followed for years to see what happened to them. And many of the patients, their skin did improve over time, even without treatment. So I would say that's one limitation, is that we don't know how these people would have done without the therapy. Maybe they would have gotten better on their own. But the fact that these patients were so resistant to treatment makes us think that they probably wouldn't have gotten better on their own. They probably would have kept getting worse. It was also a really small sample size. So anytime you do research, the more numbers of patients you have in the study, the more information you get about how the treatments work and safety considerations. And it was only 6 months. Since this publication, there has been more presentations of this data showing longer follow-up. But for this particular publication, which was, again, published in a really good journal, they only had 6 months of follow-up. So we don't know, just based on this one paper, whether these patients flared up again or their skin got worse after 6 months. That would be important to know because, again, a drug like rituximab, we would redose at 6 months. And the whole idea of this is to not have to keep redosing medications. I would say that, this study was really focused on skin disease, but as all of you are aware who live with scleroderma affects the body in a lot of different ways, not just in terms of the skin. So it would be important to know in future studies how it affects the lungs, the GI tract, and other things that bother you every day. And, they tried to look at a global measure of disease activity in the study, the U-Star Activity Index. But this index is pretty new and it misses a lot of the important scleroderma manifestations. For example, there's nothing on this index that captures GI disease, and GI disease affects most patients.
Sorry, Dr. Volkmann, we are having an audio thing. Just 1 second.
It's related to skin disease. All right. So what are the potential benefits of this treatment? And I think there's one is that, as I mentioned, it might reduce the need for long-term therapies that suppress the immune system. So for those of you who take drugs like mycophenolate and rituximab and cyclophosphamide, the longer you take these drugs, there's a greater risk that you could develop a cancer down the line. Now, that's not for everyone, but it is a theoretical risk, and it's something that we consider when we're weighing the risks and benefits, and we think about this a lot when we're deciding, do we want to take you off of treatment because you've been on it for so many years? And with this type of therapy, there's a potential that you wouldn't have to be on those drugs for as long or even at all. Also, as demonstrated in the study, there were really profound improvements in skin disease. And so potentially, if there were that profound improvements in lung disease, we could probably extend survival for patients and really meaningfully improve quality of life. I would say that most of our patients who get started on medications for scleroderma, we hope to just prevent the progression of the disease and keep things sort of stable and not get worse. But this is the type of therapy where things could actually get a lot better for you. So instead of just, feeling stably kind of bad every day, you might start to feel great. And that's the hope with any treatment for scleroderma, whether it's CAR-T or not. We really want to discover therapies that help you to feel better and not just slow down getting worse. And, if this therapy could be given early enough in the disease of scleroderma, we may be able to prevent organ damage. And what I mean by this is that if you develop scarring or fibrosis in your internal organs, there's a part of that that's reversible with treatment. But then what can happen is it can get so scarred that it's basically irreversible. And when that happens to a large degree, like for example in the lungs don't really regain their function. And we call this disease damage. And that's, again, very hard to reverse with medications. So if something like CAR T is very successful for patients, we may see less organ damage over time, less need for organ transplants. And there could be other potential benefits that we don't even know. These are all sort of what we're thinking will be the benefits, but a lot of what we know just comes from studies that were done in other diseases like cancer, which are very different than autoimmune diseases. And so that brings me to the next topic, the risk. So again, keep in mind that most of what we know about the risk of CAR T cell therapy come from studies done in patients who have different cancers. And so you have to take it with a grain of salt because, you know, if you live with scleroderma and you don't have cancer, you might have different risks involved. And someone with cancer might have a greater potential for getting these risks because they could have a lot of other problems going on. They might have just received chemotherapy or radiation. So we really need to do more studies in autoimmune diseases and patients with scleroderma to fully understand these risks. But a big one would be infection. And this would typically happen during the conditioning period, the period of time where your immune system kind of gets wiped out before you get the CAR T back reinfused in you. And so infection is a big consideration that you have to talk about with your provider if you're thinking about doing one of these studies. Cytokine release syndrome is another complication, and I'm going to explain more what this is in a subsequent slide. There's also something called immune effector cell-associated neurotoxicity syndrome, but we abbreviate this as ICANS. And this is where people can get neurological problems such as headaches, seizures. Also, there's some recent reports showing that patients can get a short-term flare of their autoimmune disease. So if they have, let's say, arthritis, the arthritis might temporarily get worse and then go back to baseline. But you can imagine if you have pulmonary fibrosis and this even temporarily gets worse, that can be pretty detrimental for your health. Secondary cancers are also a concern. And again, we know this more from the cancer literature, that there's a proportion of patients who get CAR T who get another type of cancer down the line. And again, we don't know if this will happen in patients with autoimmune disease because it could be that patients with one cancer are already more at risk for getting cancer. So we don't know this yet, but I think that's why long studies are needed to see whether this happens in the future for patients who get CAR T. And there may be other risks specific to patients with autoimmune diseases that we haven't discovered yet because we haven't done enough studies. So cytokine release syndrome is something that I wanted to spend a little bit of time on because it's one of the more serious complications of CAR T and why we still do this often in the hospital so we can monitor patients closely. And cytokine release syndrome is basically a broad term that applies to any reaction in your body where your body all of a sudden starts to produce a massive amount of inflammation. So this actually happened when people got COVID-19 and they got COVID pneumonia. Their lungs filled up with inflammation. And this is mostly what led to death for these patients was not necessarily the COVID-19 itself, it was their cytokine release syndrome. And a lot of the medications that we gave to patients who had this when they had COVID were medicines to suppress the immune system, like steroids. But cytokine release syndrome can also happen with immunotherapy. These are new therapies that are used to treat cancers. And then finally, it can happen with CAR T. And like everything in medicine, there's a spectrum of symptoms that can occur. So some patients with cytokine release syndrome will have more mild symptoms. So they might just have a fever, a malaise, muscle pain, fatigue, GI symptoms, maybe elevated heart rate or rash. And these are kind of more manageable symptoms, even though they're not ideal. But then there's some real serious complications that can happen, like pulmonary edema, where the lungs fill up with fluid, low blood pressure, and even multi-organ failure. So again, this is why if you're going to do a CAR T study, it's generally given in the hospital so you can be monitored really closely, so that if you develop cytokine release syndrome and it's a severe form of it, you can quickly go to the ICU and receive care there that you need. But I will say that, in the few studies that have been done in patients with autoimmune disease, they do see cytokine release syndrome, but they haven't seen any of these very severe cases, at least in the publications that I've reviewed. And the treatments for cytokine release syndrome is to block inflammation. So the same medications that you're trying to avoid have to be given. So the steroids and the tocilizumab, and hopefully just a short term to get the inflammation under control. Just because you have the CRS doesn't mean you need to be on tocilizumab continuously if you improve. There's other potential risks as well, and these are all kind of big words, and I just wanted to show them just to be thorough in this talk, but hypersensitivity reactions can happen. So these are like allergic reactions where you might get a rash, itchiness, fever, but you could get things like shortness of breath, low blood pressure, even heart failure or lung failure. So again, when this happens, you want to be in the hospital so you can be given treatment right away. There's also something called reactive hemophagocytic lymphohistiocytosis. Again, this can cause a lot of liver and kidney problems. And then there's other things that can happen that, maybe your B cells don't come back at all. We call this B cell aplasia. And when you have low B cells, like across the board, it can increase your risk of getting infections. And then sometimes it even affects other cell lines like your white blood cells, your hemoglobin, and your platelets. They all become low. And then you can imagine if you have low platelets, you might be more at risk for bleeding. Low hemoglobin, you might have a lot more fatigue, and low white blood cell count, you'd have a greater risk of infection. But again, in the autoimmune disease population, they haven't described these things as happening. They have occurred in the patients with cancer. But again, to be thorough, I wanted to show you what potential risks are just based on what we know about CAR T. But I mentioned when I started this talk that now we don't just have CAR T, we have other cell therapies as well. And I wanted to go over some of those alternative ones because there's actually ongoing trials now that you could participate in. And they use a different type of engineered cell, or in this table, we've called it a transduced cell. But basically the T cells are one option. Then there's something in the second row there, gamma delta cells, there's natural killer cells. So there's different types of cells that companies are exploring, but all of them are targeting the CD19 marker on B cells. So they're all going after that B cell that we talked about at the beginning of the talk. The other thing you want to keep in mind when you're considering these therapies is that, you want to know, is the therapy coming from me, meaning is it my own T cell, and we call this autologous, or is it coming from someone else or a manufactured process, and that's allogeneic. And the reason why that's important in a lot of cases is that if it's coming from another source and it's been, engineered completely in a lab, then it's considered an off-the-shelf product, meaning that you might not need to be in the hospital for it. You may just be able to go to an outpatient infusion center. It also means that researchers like me that do this don't have to do as much work in terms of collaborating with people to engineer your own T cells if we can just rely on someone shipping us a product to use for you. But that's something that, if you're considering a trial, your doctor should go through all of these. clinicaltrials.gov, which is the government database where they store all the clinical trial information. There's actually more than 200 trials actively recruiting or soon to be recruiting for different autoimmune diseases in this area. So that's a huge number. And I would say that these trials are really somewhat different than other clinical trials in scleroderma, is that they require a lot of multidisciplinary collaboration. So we know for trials looking at medications for lung disease, usually these trials involve a rheumatologist and a pulmonologist. But doing a cellular therapy trial would require an oncologist to be involved, often a neurologist in case any neurological things happen, like the ICANS, intensivists, so ICU doctors that are familiar with cytokine release syndrome and how to treat it. And also, these trials are typically longer than standard trials that we have previously done in rheumatology. So most of our trials are about a year long, and then there's usually an option to participate in an extension trial, so where everyone gets the treatment, and that's usually 1 to 2 more years. So these trials typically are much longer because we want to learn more about the safety of this and the long-term sustained improvement. And the eligibility for these trials can vary. So you may be wondering, am I a good fit for CAR T cell therapy? And I would say, at this point, we don't know because we're trying to figure out how it best works in scleroderma. And once we know that, then we'll have a good idea of who is the best patient to receive this in terms of deriving the most benefit from the treatment, but also having a reasonable risk profile. And in general, the trials now that are recruiting patients for CAR T cell therapy are typically patients who have relatively early scleroderma. So they're usually within 5 to 7 years of when they got that first non-Raynaud symptom. So when they got puffy hands or reflux disease or lung disease, just any symptom of scleroderma that wasn't Raynaud's. And many of them only want, unfortunately, patients with diffuse skin disease, so not limited skin disease. But there are now some trials coming out that will allow patients with limited skin disease if they have internal organ involvement, like interstitial lung disease. So that's sort of the landscape of the eligibility now. But again, this could change, pretty soon as we start learning about how this works in patients with scleroderma. We may see, actually this works pretty well in patients with limited skin disease. And then we might see a broadening of the eligibility criteria because personally, and I don't know if any of you have been interested in trials and have been rejected because you don't meet the criteria, but it can be really frustrating for patients and even for researchers to have patients who want to do research but aren't eligible. So I would say, I hope that in the future, all of our trials start to broaden the criteria that they look at so everyone can participate in trials. They also want to target patients now who failed at least one medication for their scleroderma. And this makes sense, right? Because we don't, there's a lot of risk involved in doing CAR T cell therapy. So I wouldn't ever recommend it as a first line therapy, because if we could give someone, let's say, mycophenolate and they got better, why put them through this whole long process? But if a patient isn't doing well, like their skin is getting worse or their lungs are getting worse, then this is a patient who would likely be a fit for the trial. And then, typically patients who've had scleroderma for decades, 15, 20 years are usually not eligible for these trials. But again, if we learn more about how these interventions work, this may come also in terms of, increasing our understanding and then offering this therapy to more different types of patients. The protocol for the trial is also different. And protocol just means the sequence of events that happens in a trial. So how the intervention is given, but also what the follow-up looks like, how many times you have to go in, what tests are done. These are very unique to each trial. So if you're thinking about doing a clinical trial for CAR T, you want to understand what assessments you'll be getting. Is it going to be pulmonary function tests? How often? Think about, is it going to be burdensome for you if you have to do a lot of skin biopsies? Each of these protocols will be different, and you'll want to have a good understanding of what you're going to go through when you do one of these trials to make sure that it just works with you and your life. And then the conditioning regimen also is typically cyclophosphamide plus or minus fludarabine. And these are the medicines that are given to kind of wipe out your immune system so that the engineered T cells can come in and do their work well. And unlike, when you have to receive cyclophosphamide for autoimmune disease, you'd be getting it, at least for 6 months. This is just given for one week. It's usually given a few times over the course of 1 week. So I don't want you to get too scared that you're going to have to get cyclophosphamide a lot. It's just given in the week leading up, usually to getting the infusion. And then Usually the CAR T is given in the hospital. There are some now cellular therapies that can be given in research infusion centers, but the CAR Ts are typically given in the hospital just because of the risk of that cytokine release syndrome and needing to be close to an ICU if you have a reaction. So this would be kind of a trial timeline. And again, every trial is different, but I looked at sort of what is out there and tried to average it out for you and summarize it. But the step one for a trial would be, your doctor may talk to you about it, you may be interested, and then you undergo what's called screening. And this is where they perform a lot of tests to make sure you're a good fit for the study. So not only, to check whether you have diffuse skin disease or lung disease, but to make sure that, you don't have something wrong with your kidneys or something that would increase your risk of having complications from this procedure. If you did meet the eligibility criteria and they gave you the green light to start the study, then, in that week leading up to the CAR T, you would get these medications like the cyclophosphamide plus or minus fludarabine to get your body primed and ready for the infusion of the CAR T. And then you'd have monitoring afterwards. And this is usually done, in the hospital. And then even after you leave the hospital, you usually have to have close outpatient follow-up. So many people who don't live near the hospital have to get a hotel or find someone to stay with so they can more easily go to their appointments. And then, like I said, the study assessments can, last for a few years, but there's even some studies that are following patients for 10 to 15 years. And I think it's great in the sense that we'll have more information about the long-term safety and effectiveness of this therapy, but it's also something to keep in mind if you're a patient. Do you want to be in a study for that long? You can always drop out of a study, but I would just keep that in mind when you're deciding about whether to do one of these trials, is that they're typically longer than other trials for, experimental medicines that we have in rheumatology. And when you're considering, doing a trial in this area, I think regardless of what kind of trial, you want to speak to the doctors who know you best to ensure that the trial is right for you. So I wouldn't just talk to the doctor who's recommending the trial for you. I would talk with another doctor as well, someone who knows you, because sometimes doctors who do research have a bias towards really wanting to get a lot of patients in their studies. I am not this way. I'm a doctor first and then researcher second. So I always want to do what's best for the patient. But some people get really excited about recruiting into trials. And so because of this, I would just err on the side of caution and talk to another doctor just to make sure they also agree. And I think this is a good rule of thumb for anything in medicine, right? If a surgeon recommends a surgery, you might want to get a second opinion to make sure that both doctors agree. So I would talk to a couple of doctors if you're considering one of these trials, and then find out if the site where the trial is being conducted is doing cellular therapy trials in other areas. So for example, many of them may not have had experience in autoimmune disease because this is a pretty new indication, but they should have experience with cancer. So you want to go to a center where okay, there's oncologists there that know what they're doing that will help me in this journey. And then even find out, are there other patients with your disease who participated in the trial? And it doesn't have to be at the specific center where you're seen, because they might have just opened the trial and you happen to be the first person coming on the day when they started recruiting. But see whether, maybe at another site around the country, there could be someone else. And typically they could even give you information about, how that person's doing if it's a trial where everyone gets the intervention. And then what you also want to find out, again, from your team of doctors, are what are the risks for you? So I mentioned sort of general risks of CAR T therapy, but the doctors who know you best also know your underlying health conditions. So for example, if you have diabetes, that increases your risk of having infections. So it's just something to keep in mind if you're doing a therapy that also increases your risk of infection. So this is something that's very personal to you. And I think risk assessment really should be done by the doctors who know you best. The other thing I would consider is that, if you have to do a lot of follow-up in this study, you want to make sure that the company that's sponsoring the trial is going to cover the cost of your transportation, even housing. If you have to go back and forth a lot and you live far from the hospital, it might be easier to stay closer to the hospital if you don't need to be in your own home during that time. In a city like Los Angeles, where I live, sometimes going 5 miles can take an hour and a half. I know that sounds extreme, but it's quite true. And so, for all the trials that I offer for my patients, I make sure that transportation is covered. Also knowing that, many of my patients don't drive. They have difficulty with their hand function, and it's just easier for them for transportation to be provided. And most of these companies have the resources to do this, so I would definitely ask. And then the other thing you want to do is if you're doing a trial that has a placebo arm, meaning that you enter the trial and you have a chance of getting the CAR T, but you also have a chance of not getting the CAR T, you want to find out, are there any restrictions on what medications I'll be allowed to receive if I start getting worse in either arm? So, some of these studies are designed so that they really don't want patients getting a lot of different medicines because it confuses how they analyze the data. But if I'm a patient, I want to make sure if my lungs are getting worse, I have access to every therapy I may need. And so ask your doctor this question, because again, there are some studies that restrict this. There are other studies that don't and would just allow your doctor to treat you as if you were in the trial. But you need to find this out to make sure, there are options for you if your lungs or skin or some part of your scleroderma starts getting worse. And then obviously, if you're in a hospital, there should be an intensive care unit, but that's also a consideration just as a safety net. And then also the support through the trial. I think sometimes these study days can be rather long. There seems to be, even just with regular clinical trials now, a lot of assessments that are done where it can take a whole day to participate in one study visit. And so for, a patient, they might want to have a support person with them. And if you have someone who's a caregiver to you or a friend who could come with you for the day, make sure that's okay. I think it's a great support system. And also, you could see if the sponsor would provide coverage for their transportation costs as well. Especially because some people are even flying on airplanes to do these trials. And that's another issue, is that if you do decide to do one of these trials and have to fly to the study site, I would try to do this flying, not during the winter or flu season, just to lower your risk of getting an infection while you're traveling. So how do you find a trial? And this is another important consideration, because you may be seen by a doctor who doesn't participate in these trials or lead them, and that's okay. I would just talk to that doctor first and express your interest, and they may know someone, right down the hall that's doing the research, or in the institution, on the other side of town, or even somewhere else in the state. But I think asking your doctor is a good starting point. If they don't know, you can also get information on the internet. And I'm going to go through the two options that I think are the best options for finding information about trials for patients with scleroderma. So the first is actually the National Scleroderma Foundation put together a trial database, and this is, wonderful. And I know that the organization has worked really hard on this effort. So this is where you could go to this website, and I've listed it at the bottom here, and you're welcome to take a picture. But this can provide you with information about where the trials are being conducted, who the investigators are, and to see if there's a right one for you. The other option is the clinicaltrials.gov website that I mentioned earlier in the talk. The website is also listed at the bottom here. Now, just note that when you go to this website, it can be a little overwhelming, and you're going to have to search it, because it's every trial that's being done in the United States. So you can imagine there's a lot. So you want to focus your search, and there's a search tool where I tried this out, so it worked. You want to put in systemic sclerosis. I wouldn't put in scleroderma, because you might get other diseases like morphia, et cetera. But this is really, this CAR T right now is just for systemic sclerosis. In terms of the intervention, you could put in CAR T, but I got a better search if I put in the word cell therapy. Then you would put in your location because then it would give you options closest to you where you live geographically. And then this last step is really important. You want to select recruiting and not yet recruiting studies. So these are going to be studies where either they're open and they're ready to accept patients, or they're soon going to be ready to accept patients. If you click all studies, you're going to get every study that's been done in this area, even the studies that are close to enrollment. And it's just going to be a pain to go through. So I would try to focus on the recruiting studies. So when you do that and you click search, what happens is, these things start popping up. And so this is just an example of what one looks like. This is the RESET SSC study that's ongoing. And you can see here, it shows that there's 10 locations doing it. And if you click that hyperlink, it will list all 10. And then if you decide, okay, well, I live in New York, so New Haven is actually pretty accessible to me, then you would click on that. And then it would tell you, okay, in the Connecticut location, it's at Yale University. It gives the principal investigator, that's the doctor like me who's overseeing the trial, and usually a scleroderma specialist or an oncologist. And then it would list the contact, and this is usually the study coordinator. So you could either call that person or email them. And this is usually a pretty up-to-date list, I would say. So I think this is a good option if, like I said, your doctor doesn't know. This is another way to find these trials because there's a lot of them now, and some are being done by real big pharmaceutical companies, some are being done by smaller ones. And the best way is just to see what is, closest to you in your area. What are the unanswered questions? And again, I wanted to leave some time for your own questions, but these are some of the things that we need to learn more about as we do this research. So I think one of the questions is, will this type of therapy lead to a sustained remission of scleroderma or other autoimmune diseases? Meaning, if we give you the CAR-Ts, do you get better and then never need mycophenolate or rituximab or any other treatment again? And that we will only know when we start to follow patients long term. I will say with autologous stem cell transplant, which some of you may have heard of, this has been around for a longer time in scleroderma. And I see a lot of patients in my practice who got autologous stem cell transplant, got better, but then all of a sudden their scleroderma got worse again and they're back on mycophenolate or back on rituximab. So what we want to see with cell therapy is that over time there's sustained remission, because if you just have to go back on these treatments, there's really no point of going through this big procedure with a lot of risks. We also want to know more about the long-term risks because, the cancers that happen in studies of patients with cancer may have just been related to those patients being predisposed to cancer. So we need to know, are you at risk for getting cancer down the line? And if so, that has to be part of your equation when you're thinking about whether or not to get this therapy. And then a big one, unfortunately, that we deal with all the time in the United States is insurance companies, and will they cover this in the future? And so hopefully, if there's enough of these positive trials, this will become an approved indication. But sometimes, as you may know, even when a therapy is approved for a disease, it doesn't necessarily mean that your insurance company will cover it, or they may cover it, but you'll have a really high copay. And this has happened, for some people who have cancer, where they might be a great candidate for CAR-T, but their insurance doesn't cover it, or they're just not anywhere near close to a center that has it, so it's just not feasible for them. Another question is, will it help other parts of scleroderma? Right now, they're really focused on studying skin and lung disease, but my hope is that, for example, we'd be able to see that it prevents progression of the GI disease. And if any of you came to my talk this morning, you know that we don't have any approved therapies for GI disease and scleroderma. It troubles a lot of patients with this disease. In fact, over 90% of patients have GI disease. So it would be really great to understand how this therapy affects the progression of GI disease. And I'm hoping that studies in the future will consider this. And then finally, if these therapies are safe and we don't see a lot of this cytokine release syndrome and patients don't need to go to the ICU after they get it, then perhaps this treatment could be given safely outside of the hospital. And I would say that's definitely more desirable, because every time you go into the hospital, not only is it the hospital and kind of traumatic, but you're also more at risk for getting hospital-acquired infections, and it's just a greater burden in terms of your life and family. So I would say if this proves to be a safe therapy, then it might be given outside of the hospital in the same kind of infusion center where you might receive, let's say, rituximab. So in summary, CAR T and other cellular therapies represent a really promising treatment option for patients with scleroderma, but all of these therapies right now are investigational. None of them have been FDA approved, and future research is needed to understand who will benefit the most from this cell therapy and what the long-term risks are. And I want to thank you for your time today. This website and QR code is a link to a newsletter that I send to patients every month with tips about their scleroderma, particularly focused on nutrition and self-care, but other things that you can't always get to in your visits with your doctors, but could be helpful to know. And I invite anyone who wants to receive it, you can. And if you don't like it, you can always unsubscribe. But thank you so much for your time. And I'm really excited to answer any questions you have.